the patient outcomes we've achieved, which many of which have been as a result of a federated activity, but also some as a result of our local participation and our local activity. A couple of the big ones, accident and emergency performance at Royal Berks has been a challenge for us the whole year, but at a federation level, fully supported by CCGs, we've invested more money in Royal Berks, we've cajoled them, and we've I think we're beginning to show some improvements. They are beginning to meet their targets. We also have a very robust risk register, which is created at federation level, but is reported to CCGs at each of their board meetings, and that does show up where we have patient shortcomings and financial challenges and all the rest of it. And that's worked very well. We've been able to get on top of stroke times, diagnostics. We haven't solved all these problems, but we know exactly what the challenges are, and we've used our muscle as a federation to try and get providers to do better. We've also, though, got, as well as that sort of overall strategic stuff, there are local targets which have been introduced for each of the CCGs, practices and all the rest of it. I mean, we've had bowel cancer screening as one of ours in North and West Reading, and there are others, and the benefit of that has been that we pilot it and then it spreads out to the rest of the CCG and to the rest of the federation as well, and that's another benefit of federation working. We're also very proud of the fact we have clinical expertise, which just isn't limited to just our CCG, because we've got the federation. We have clinicians leading on things like diabetes and COPD care and such like from other practices outside our CCG, and vice versa. Our CCG leads on things which other CCGs can then feed from. So very good sort of coordination, if you like, on a clinical basis too.
I think one of the very strong unique selling points of Berkshire West is the locality working that allows certainly the clinicians to focus on the local population, and it maintains that focus of locality, but gives the federation also the power to be able to commission with clout, as one of our chairs calls it. The shared roles we have across the federation gives that good overarching view of everything. So the chief executive, the finance officer, the nurse director and secondary care consultant are really important to be able to give that overview and to provide insight that we wouldn't always get, and it's good use of clinical time then not to be attending 4 different meetings.
We've got very strong leadership from both the chief officer and the clinical chairs in all of the CCGs. We've had strong federated leadership, so Rod Smith, as chair of the sort of federation, has been around since the inception of the CCGs, and prior to that all the development work that went on the year before. I think that's been very strong. I think we've got a strong team generally. Where we have, we've also got a very self-contained, largely health economy. So for South Reading CCG, for example, probably 95% of its business is done with the Royal Berkshire Hospital. Less so for the likes of Wokingham, and even more less so for Newbury. But largely it is a sort of self-contained health economy, which I think is helpful. Financially, the CCGs are slightly different, but we have risk-sharing arrangements, financial risk-sharing arrangements in place across the 4 CCGs, which enable some of that volatility that you would suffer from as a small CCG to be effectively managed. So, for example, where we've got high-cost mental health placements or high-cost continuing healthcare placements, the CCGs have agreed to a risk-sharing arrangement across all 4, because you could find that there's a lot of expense in one area one year and it could pop out in another one the subsequent year, and you've not really any control over that. So we're seeing sort of so mental health placements, high-cost mental health placements, a particular issue in South Reading. Continuing healthcare, high cost has been a particular issue in Newbury. So we've sort of spread that risk, and I think that is good in terms of federated working. That we've got good engagement across the 4, so there is an arrangement whereby decisions have to be made, and there needs to be 3 of them signed up for something to go through. 3 out of the 4. We've not really had anything that has been had to go to an explicit vote and has been pushed back.
I think one of the key benefits of the federated structure with 4 CCGs is that you have the ability in committee meetings or whatever it might be to have a sort of peer clinical review of what the CCG may be proposing. So you can have the clinical members of another CCG passing comment on something that they know about, which perhaps the members of the governing body, like me, the lay members, wouldn't have an alternative view from the clinical members of the CCG. So that peer review is very useful, both in terms of additional information and also to avoid any sort of potential conflict of interest pitfalls that might be which the lay members, for instance, may be unaware of.
Okay.